Hello doctors, in this liver series, we are moving on to infections of the liver. So beginning with the liver abscess. There are two types of liver abscess. It can be amoebic liver abscess or a pyogenic liver abscess. In this module, we are going to focus more on the amoebic liver abscess. The next video will deal about the pyogenic liver abscess. The amoebic liver abscess is caused by a parasite called Entamoeba histolytica. Okay. This Entamoeba histolytica exists in two forms. One is the cyst form and another is the trophozoite form. The cyst form is the infective stage. Okay, this is the one excreted in the feces, and once it is ingested via contaminated food or water, it enters the intestine, enters the esophagus, the stomach, and then the small intestine. In the small intestine, it causes erosion, necrosis of the small intestine, and it enters the portal venous system. The small intestine is eroded, it has necrosed, it forms small ulcers, and finally it penetrates into the portal venous system. As you can see, this is the portal venous system. So in this portal venous system, these are the branches that take up blood from the small intestine. The portal vein divides into how many branches? Yes, it divides into right and left branch inside the liver. So once it goes inside the liver, the right branch is known to have a laminar flow. Okay, so there is a constant laminar flow. There is no turbulence in the right side. And also the right lobe is very large. Therefore, it is very easy for the parasite to stay in this bare area or the seventh segment. In the previous video, we learned about the coinoid segments. So it prefers the postero-superior or the seventh segment, which consists of the bare area of the liver due to the laminar flow and the large lobe. Okay. So what does this Entamoeba histolytica do to the liver? This releases something called histiolysin. The histiolysin is nothing but a cytolytic agent. It causes lysis of the cell and eventually lead to amoebic hepatitis. Hepatitis is what? Nothing but inflammation of the liver. There is inflammation happening in the liver plus infection also. So it leads to formation of various micro abscesses. These micro abscesses eventually undergo liquefactive necrosis. Know one thing, whenever there is an inflammation, there will be lots and lots of neutrophils. But here is the change over here. So in liver abscess, you won't find much of the neutrophils because these are lysed by the trophozoites. The trophozoites lyse this neutrophil, which leads to further liquefactive necrosis, and eventually this necrosis causes the blood vessels to thrombose. When there is a thrombosis in the blood vessel, as and when the RBC passes through it, it will cause lysis of this RBC. The lysis of the RBC will lead to release of the pigments. So whatever the pus is present inside this liver abscess will nothing but have a colored appearance. The color will be chocolate brown. Okay, so we call this as the anchovy sauce. Anchovy sauce is a sauce that we obtain from anchovy fishes, which looks somewhat like this in color. So this is a thick chocolate brown necrotic hepatitis, consists of necrotic hepatocytes, and there are no pus cells. As we saw there, the neutrophils are lysed. So there are no pus cells present in this. And one more thing to know, this is totally sterile. How can this be sterile? You should ask me that it consists of infected foci. Entamoeba histolytica is the one that causes it. Then why is it sterile? The answer is very simple. This is the liver abscess and this is the cyst wall. Okay, in this liver abscess you have the cyst wall. The Entamoeba histolytica actually resides in the walls of the cyst wall and does not enter the sterile pus. So since it does not enter the sterile pus, the pus is sterile. So occasionally when the trophozoites enter, only then you can find some trophozoites inside this cyst. Okay, they multiply only in the wall. So thus we can see that it is a sterile abscess. Okay, don't think this to be the anchovy sauce. This is the pus inside the amoebic abscess. Okay. Here in this picture you can see the pus and the big abscess you can see. On a chronic period, it can also get capsulated and calcified. Moving on to sequelae. What are the complications of sequelae of this pus? Any pus can rupture, and rupturing of pus is a very serious sign as it leads to various other manifestations also. As you can see here, anatomically speaking, this abscess can rupture anywhere in and around itself. So we have to be strong about the anatomy of this area. As we know, the most common side is the posterior superior region, and the region surrounding the posterior superior region is above you have the bare area, behind you have the subhepatic region, and then you have the pericardium over here, you have the lungs, you have the pleura, you have the bronchi inside the lungs, you have the intestine directly below it, and definitely you have the peritoneal cavity. You also have the common bile duct. So the abscess can rupture into any of this region. Okay, so let's see what it manifests whenever it ruptures into these. When it ruptures into the lungs, we used to cough. We will cough out sputum, and the sputum will be colored. It will be chocolate colored. Okay, when it ruptures into the peritoneum, we have peritonitis. Will manifest with rigidity, guarding rigidity, and rebound tenderness. When it ruptures into the bronchi, the bronchus of the lung, you can have fistula. Bronchopleural fistula can form. Once the bronchopleural fistula is formed, we can cough out anchovy pus as a whole. Then it can rupture into the intestine. It can also rupture into the pericardium, and this is a very serious threat. It can lead to constrictive cardiac tamponade and constrictive pericarditis. And cardiac tamponade is a really serious condition and needs immediate intervention. Definitely in peritonitis also you need an immediate intervention. An open laparotomy is needed. And when it ruptures into the bare area, it can form a retroperitoneal abscess. Okay. As you know, it affects the liver. There's no doubt it can cause septicemia as well as hepatic encephalopathy. When the condition worsens and it leads to cirrhosis, these conditions can manifest. And lastly, butt shearing. Why does it cause butt shearing? Okay, a simple logic says that the abscess is growing. A growing abscess can compress the IVC or the hepatic vein. The hepatic vein or the IVC can be compressed. So compression of this drainage system will lead to nothing but the butt shearing, right? So we have seen all the sequelae. Let's just brief it. It can rupture into the lungs, pericardium, the peritoneum, the intestine, the bare area. In the bare area, it can form a retroperitoneal abscess. Okay, and other than that, it can cause hepatic encephalopathy, septicemia, and butt shearing. Now, how will the patient present? It's very simple if you know the concept. This is the liver, right? And the abscess is over here. First of all, you should remember is, it is an infection. So the patient will definitely present with all the infectious symptoms. He will have fever, right? So the patient presents with fever as the major symptom. When in an acute stage, he can also present with chills and rigors, to be remembered. In a chronic stage, the patient can present with loss of weight. Okay, and as we already seen, when it penetrates the lungs, ruptures into the lung, there can be cough also. Other than that, these are the general causes due to the infection. These are the general manifestation that is caused due to infection. But let's see specifically, a liver abscess is present in the right side, that is the right hypochondriac region. So you will have pain. Any pus-filled region will manifest in the form of pain at the right hypochondriac region. Followed by, you will have an intercostal tenderness. Okay. So all these are the general clinical manifestation that you will see. There will be also a history of amoebic dysentery. Okay, only after the history of amoebic dysentery, you will have the liver manifestation, because we saw in the microbiological aspect that the amoeba enters via the small intestine. It erodes away, it causes necrosis. So there will be amoebic dysentery, only then it will enter the liver. So there will be a history of amoebic dysentery. And the patient, once manifested with the liver disease, will present with fever, loss of weight, non-productive cough, and when it enters the lungs, it will produce a productive cough which is chocolate brown in color. Okay. And there can also be a right hypochondric pain, intercostal tenderness, right pleural effusion. For our ease, we just divided into two: acute features and chronic features. Acute features presents with fever plus chills and rigor. There is a tender, soft, palpable liver. And there is intercostal tenderness. Whereas in chronic, the patient presents with a firm or hard, smooth, non-tender, palpable liver. Since it's a chronic condition, there won't be any tenderness. Okay, and there is no acute feature. There is no fever since it's a chronic condition. Okay. Now, what are the investigations you are going to do? You're going to take blood sample in which you're going to run the CBC. Total WBC count will be increased because there is infection and inflammation. But remember, the neutrophil count will be at a lower level. The hemoglobin will also be reduced. In the liver function test, you can see that the liver function test will be totally deranged. In ultrasonogram, you can find hypoechogenicity or anechogenicity. And ultrasonogram will be, USG will be useful to know the size, number and location. Fourthly, the CECT, contrast enhanced CT. This is the investigation of choice. The abscess cavity appears to be low in density. So you can see the size of the abscess, how big it is, whether you the size, it is important for the management, whether you can give it a medical management or get into a surgical management. So for that you have to know the size, you have to know the location in order to give in order to intervene. You should know the number of abscesses present and if there is any lung changes or effusion in the lungs. There is also one more test called the serological test, in which we do indirect hemagglutination test or ELISA, but it is not that effective as it is positive even after the infection eradication. It actually detects the galactine present. So these are the overall tests that you will be doing. You can do blood investigation, LFT, ultrasound, CECT and serology. Now how are you going to manage this patient? The management includes the first, medical management. So as you can see, the parasite is first present in the intestine, followed by which it goes into the liver. But the clinical manifestation is majorly of the liver. So you are first going to eradicate the tissue, the organism present in the tissue, followed by you have to totally eradicate the organism present in the intestine. So we have medications that eradicate the tissue amoeba, that is the tissue amoebicides, and the luminal amoebicide that eradicates the infection from the intestinal lumen. So let's say what are these medications. For the tissue amoebicide, we give metronidazole, 800 mg TDS. This is a very high dose and it will be very awful for the patient to take this medication. So you are giving it for 4 to 5 days. After 4 to 5 days, you'll see that the fever and the pain subsides. This means there is a good response to the treatment. When the fever and the pain subsides, you're going to continue it for 2 to 3 weeks. Once you continue it for 2 to 3 weeks, you're following it with luminal amoebicide. In the luminal amoebicide, we have diloxanide furoate and you're giving it for 10 days. Okay. So in the medical management, what are you going to do? You're going to give metronidazole and diloxanide furoate. You're giving metronidazole for 2 to 3 weeks. The fever and pain subsides means a good sign. And followed by you're going to give diloxanide furoate for 10 days. But if these conditions are not healing, what you're going to do? You're going to do an ultrasound or CT guided pus aspiration. What are the indications to get into an ultrasounded or CT guided pus aspiration? First of all, when the pus is very large, the abscess is very large, that is more than 5 centimeter, when it is an infected abscess, when it occupies the left lobe. We have seen that the abscess is more common on the right side. Being on the left side includes lots of other problems and complications. So whenever it is on the left lobe, we have to go at a higher level of treatment. When it is seronegative, when the woman is pregnant, in a pregnant woman you can't give metronidazole. And when there is an impending rupture, in all these conditions you have to immediately deflate the abscess. So you are going to ultrasound or CT guided pus aspiration. Under pus aspiration, you are going to do a percutaneous drainage using a pigtail catheter. As you can see, you are going from the front, or you can go from the 8th intercostal space in order to drain the abscess. Okay. Even if this percutaneous, even when this percutaneous aspiration fails, you can go to the next method, which is the surgical method. A failure of, what are the indications for surgery? A failure of the repeated aspiration. You're aspirating the pus repeatedly, but it is coming again and again. So what are you going to do? You will go into surgery. When the pus is very thick that it can't be aspired, and it is a pus present in the left lobe, and it is a ruptured pus. Whenever it's a ruptured pus, you have to go it laparotomically. You have to open the abdomen. Okay. So what are you going to do? You're going to do a transperitoneal drainage. You have to open it. You're going to drain it, and you're going to insert a Malcott catheters. The Malcott catheter will help. It to help the pus to be drained. It's an open drainage system. Okay. Followed by that, at the time of discharge, you're going to give the patient chloroquine 250 mg BD for 10 days and diloxanide furoate 500 mg TID for 14 days. Okay. As you can see, this is how a Malcott catheter looks like, and this is how it is inserted. And the Malcott catheter itself is an important topic. As you can see, the tip is flower shaped, so it cannot be inserted via the urethra. Okay. So we use it for suprapubic catheterization as well as for pus drainage in this situation. We'll deal about the Malcott catheter totally in a different video. Okay. Let us see into the complication of the surgery. Definitely there will be some anesthetic complication. There will be bleeding manifestations. It can also go into liver failure, and intraperitoneal abscesses can also form. You have to follow up the patient. How are you going to follow up? You're going to advise the patient to avoid alcohol. The LFT needs to be repeated. A repeat USG should be taken till the disease is completely resolved. Okay. So let's see a summary of the whole video. There are two types of liver abscess, amoebic and pyogenic liver abscess. Under amoebic, we saw that it is caused by the entamoeba histolytica, which the infective form is the cyst form, which is present, which is excreted in the feces and ingested via the contaminated food and water. It enters the small intestine, changes into a trophozoite. It erodes and necroses the small intestine, enters the portal system. Via the portal system, it enters the liver. Most common site is the bare area or the 7th segment, which is the right postero-superior segment. Okay. It releases histiolysin that causes thrombosis, RBC breakage, and formation of the anchovy sauce, which is thick chocolate brown necrotic hepatocytes. And the important thing is it's a sterile abscess. Okay. The sequelae can be ruptured. It can rupture into any part. What are the clinical features? Clinical features will be a history of amoebic dysentery, a past history of amoebic dysentery. And one more thing to know, it is more common in males. The male to female ratio is 10:1. Okay, there's a history of amoebic dysentery, and definitely since it's an infection, there will be fever and loss of weight, and there will be a right hypochondrium pain and intercostal tenderness. The manifestations are different for the acute and the chronic condition. What are the investigation you are going to do? An ultrasound, LFT. And then the management. The medical management involves the tissue amoebicide and luminal amoebicide. And then you can do a pus aspiration or a surgical management. Thank you.